Are we good to go now? Good. So, morning everyone. My name is Stanley Masunda. I'm going to be discussing distal radius fractures with you guys. Firstly, I'd like to thank Meadow and Mr. Oladeji for inviting me once again to come and speak to discuss with you guys regarding these injuries, which are, I think, in our profession are very common and we tend to see on a daily basis. So it would be good for anyone with an interest in orthopedics just to get an idea of the principles behind trying to manage these patients. The objectives of the course will be obviously to go through the introduction, a brief touch on the anatomy, and then discuss how patients typically present. We'll go through the imaging of these fractures, which is mainly going to be X-ray based, treatment, and the complication that might arise. So as an introductory note, we know that in the UK we see more than 1/6 of the fractures that we see are distal radius fractures. So they are quite common, and the incidence has been increasing from 2 people in about 1,000, rising to about 12 people now in 1,000 in those who are over the age of 85. And I know typically when these were usually described in the past by colleagues and colleagues, they were mostly seen in postmenopausal women. So there is a high, I think, incidence in females as compared to males, as demonstrated there. We do get a bimodal distribution. So in younger patients, it tends to be a high energy mechanism, whereas in older patients, it's usually just a simple form or low energy mechanism. On the anatomy, so basically, the part we're trying to describe, if you can see my cursor, is just about from the joint line to just about where the images show that that's the distal radius part we're trying to look at, which is the lower third of the radius. And some important anatomical features maybe to be aware of are the radial styloid, which would be very important when looking at these injuries, because at times it can inform stability or instability of the fracture. It's also important to look at the distal radial ulnar joint, which is an important aspect as well, which helps you get a picture of how stable or a fracture is or how well you've reduced it as well. Looking from the dorsal side, or which is the back side of the fracture or of the distal radius, I think an important aspect to look at is the dorsal tubercle of the radius, which is the listus tubercle. It is important mainly because of just where it is, and we know that the EPL, or the extensor pollicis longus tendon, winds just around there as it goes towards to insert in the thumb. So it's just things just to be aware of. I know we typically call these fractures wrist fractures, but what we tend to mean is fractures going around just about the distal aspect of the radius. Although we know that the wrist, specifically speaking, would be this radiocarpal joint. But then I think when we say wrist fractures, from henceforth, we'll be describing to fractures around the distal radius. And then also just other important things to know. The volar side means the front. I know you already know this. And then the dorsal side means the back, which is what will be, I think, the are the terms that we tend to use as we describe these fractures. Simple radiological anatomy. The X-ray that we usually try and do are PAs. So from the back, an X-ray being shot from the back to the front, which shows you what you can see on the left side here of the screen. And this is the lateral view as well. And basically what you're trying to see looking at this important landmarks that can help you determine how the distal radius alignment looks. And what I mean by that is there's about 3 aspects that we try to look at. So we try and measure what we call the radial height, which is a distance from the tip or the top of the radial styloid to the bottom of the radius, just as it joins the distal radial ulnar joint that distance is usually about 11 millimeters. And then we have a radial inclination, which is an angle from the tip of the radial styloid to just about there. If you draw a transverse line, which is that this angle that you're looking at should be about 23 degrees. And then when you look at it laterally, so if I should move back, so what we've been described is the angles you can measure on the PA X-ray, the radial inclination, the radial height, and then on the lateral view, you're trying to measure where the radius is facing. Is it volally facing, which it usually is, which is a 10 degree angle. So if you draw a line from the top tip of the dorsal aspect, the back of the back of the wrist, if you draw a line from there to the top of the volar aspect of the distal radius, and then you make an angle through there, that should be 10 degrees, meaning that the radius is not always facing straight. It is slightly tilted by 10 degrees facing to the front or facing volally. And those important, I think the way to remember it for myself, I usually say 11 times 2. So 11 millimeters, 11 degrees times 2, 22 degrees, 22 degrees of radial inclination. It just makes sense, and I've always used that. So I think for people who don't want to be working a lot, you can use that to help you remember these angles and measurements. So patients usually present, mainly we see elderly patients in our population who've had a simple fall. So they've either tripped and fallen on their outstretched hand, and then they come in with a typical, what we call the Jideofor Colles fracture, which means the hand seems more to the back and the rest of the arm seems slightly to the front. So almost like a picture like that. But then you also tend to, it does occur as part of a high mechanism of injury, which is also very important to anyone working in A&E and orthopedics, because you should treat the patient as a whole. So make sure that we've gone through those ATLS, ABCs to make sure that we've ruled out any life-threatening injuries before we do anything else for the patient, because it's well and good to fix a fracture, but it is not helpful to the patient if you've missed a life-threatening injury. For those who have just come in with an isolated fracture, they usually complain of a swollen, painful, and usually often deformed wrist that you can see clinically. Like I said, you have to rule out any other injuries. I think another important aspect is to rule out any associated neurovascular compromise, particularly the median, the ulnar, and the radial nerves. And you can do this quite simply by checking for the sensation and the movement. So the way I tend to do it is looking at the first web, the dorsal first web space just depicts the radial nerve, and then the ulnar tip of the index finger, and then the ulnar for the median nerve, sorry, and then the radial tip of the index finger depicts the median nerve, and then the ulnar tip of the little finger just depicts the ulnar nerve. And then simple movements such as OK sign, you're bending the IPJ in from the thumb, and the DIPJ from the index finger, which is supplied by the median nerve. If you ask the patient to open or make a paper, you're measuring the ulnar nerve as well. And then just simply asking the patient to extend their wrist or their hands helps you measure and assess the radial nerve. And also very important, I think, to identify and document any associated soft tissue injuries. So if there is an open wound, you really need to address it, identify it, document it, together with the neurovascular status of the patient, because that will determine how this patient is managed ultimately. So when we're assessing and treating these patients, you want to consider their age and their level of activity. So the way you treat a patient who's 99 years old with a distal radius fracture, who's basically maybe in a care home being looked after, not very mobile, would be very different to a business executive in London who's in the mid-80s in a high functioning job. And you want to know if the patient is right-handed or left-handed, and particularly what they do. This becomes a very important aspect if these patients would do a lot with their hands, so either sports people or manual laborers. They would really be keen to try and get a highly functional wrist as soon as possible. You also want to look at the nature of injuries as discussed before, whether it's a single bone or polytrauma. If it's a polytrauma patient, then you prioritize life-threatening injuries first and then progress down towards less life-threatening injuries. And it's always important to have an open and honest discussion with patients regarding their expectations. Fractures that you might think need surgical intervention, some patients might have very, very strong feelings to say, you know what, doc, I would rather you just leave this as it is because I just do not want to have surgery. And some patients might have very strong feelings towards having their fractures surgically fixed, fractures that you feel shouldn't be fixed surgically. So that discussion and relationship with your patient from the start is very, very important. You also want to look at the images and look at the displacement of the fracture. More severely displaced fractures will obviously warrant a bit more treatment than just a simple conservative pull and immobilize. Whereas just simple undisplaced fractures might just need a wrist splint. So I think it's just things to consider as you're seeing the patient, as you're looking at the X-ray from the start, just to try and categorize where you think these patients might fall into. And the mainstay of investigation from our side is mainly X-rays. And you should always remember the rule of twos. You should remember that all these patients, when they come, they require 2 views of X-ray. So it's not good just doing an AP, because just a simple a PA X-ray might not show you the full extent of the fracture. You want to make sure that there are 2 joints that have been X-rayed, so the joint below and the joint above. You want to make sure that you get 2 clinical opinions, either from a colleague or a senior colleague. You want to make sure that these patients are usually X-rayed in 2 occasions. Usually we tend to do that quite routinely in our unit. So we X-ray the patient when they come in and they initially present, and then you can always X-ray the patient after you usually put a back slab as well. But then if you still have concerns, particularly in children, you can always X-ray both limbs. Although I think we get a lot of angst from the radiographers and the radiologists in terms of X-ray exposure for kids. And for patients who require surgical intervention, or patients that are not completely clear about the full extent of the fracture, you can always do a CT scan. And that helps with surgical planning in terms of what approaches you're going to use and how you're going to fix the fracture. And also looking at intra-articular involvement or extension of the fractures to see which fragments are being affected and how best you will need to immobilize and what systems you're going to use and principles. If you are then given an X-ray of a patient with a distal radius fracture, there's no need to be afraid. You have to try and describe it in a systematic way, looking initially at the most important thing. Are you looking at the right X-ray? So the adequacy of the X-ray, you want to look at the bone, look at the cartilage, and look at the soft tissues as well. So the ABCS rule of looking at bone X-rays is always important and handy to try and use. So simple things. If you're looking at the adequacy, you want to see, is it the right patient you're looking at? I know it sounds pretty simple, but there's been times when, you probably also know where people have looked at the wrong X-ray, come up with a marvelous diagnosis, but unfortunately for the wrong patient. You also want to look at the age of the patient, the hospital number, and the date is very important because some patients might have previous X-rays of a similar fracture or on a different limb. So it's always good to just make sure that you're looking at the right side. Look at the views, look at the dating of the imaging as well. Look at the location. So you want to describe the bone that is involved. You want to look at the position. Is it happening at the distal aspect of the radius or proximally? You want to describe if this fracture is complete or incomplete. You want to use terms such as, is it a simple fracture or is it a complex fracture? There's some important aspects that you're seeing from the fracture. Is the radial length now shorter? How is the apposition of the fragments? Is one fragment completely off-ended, or is there any rotational deformity that you can see? So all those simple aspects of the displacement are important to describe. And you want to move on and describe any cartilage involvement, particularly important in kids who whose growth plate are still visible and are still growing, because that determines again how you want to approach and fix and treat these fractures. Soft tissue involvement we've talked about. You want to look at obvious swelling, emphysema, and at times you might see a bit of bone poking through the skin. So you can also describe that. I can conclusively give you an idea if a patient has an open fracture. But oftentimes, open fractures are just a clinical diagnosis that you have to note and document. So, as an example, so going through the A, so in this patient, we know that there is no obvious, it's not an adequate image because we can't see the patient's name, we can't see the date of birth. There is no obvious time when this was done, but there is indeed the side. So we know it's the right side. And as we look at the bone, it is a distal radius fracture. And then we describe this fracture, it is displaced dorsally. And the way we describe this is we always want to talk about where the distal aspect of the fracture is in relation to the proximal aspect of the fracture. So looking at this lateral x-ray, we know that the distal part is this one as compared to that one. And this bit here is at the back as compared to this one, which is at the front. And how I know that this is the back as compared to the front is I always look at the thumb. This is the thumb there, and this is the first CMC joint. Wherever this is the front. Wherever this is not, it's the back, which is that. So this is a dorsally displaced transverse fracture of the distal radius with what appears to be some comminution around there. The fracture is dorsally angulated, as you can see from there, that this cup is meant to be facing to the front, but it seems to be slightly flat or just about facing the back. And you can also then discuss that it is not completely displaced, but what we can see as well is that there is a line which looks vertical and it's quite translucent as well, extending to the joint line. As you can see, but there is no obvious step on the joint, and there is no obvious gap that you can see as well. So this is just particularly describing the distal radius. And you can see also, commenting on the soft tissue, that there is a bit of swelling in that in the soft tissues as well. So this also informs that this could be an acute fracture. At this point in time, I know there's a small ulnar styloid fracture. We will ignore it for now. But once you've described this fracture, you should describe it in a systematic way such that the person on the end of the phone knows what you're talking about, and then you can discuss a plan in terms of how to treat it. Just some simple fractures that we will come across and that have been eponymously described in the past. We know the Colles fracture is a low energy displaced dorsally displaced extra-articular fracture. So it's a fracture which is not involving the joint. And it's extra-articular, usually common in elderly females. Again, dorsally displaced. First thumb. So this is the front, this is the back, and we know the distal radius is at the back. So it's a distal radius fracture, which is dorsally displaced. And you can almost see that typical Jideofor appearance if you look at the soft tissue all the way through there. If you look at the soft tissue definition, you can almost see, that dorsal, that Jideofor appearance of the fracture. The Smith fracture is the opposite of that. It is a low energy, volally displaced extra-articular fracture of the distal radius. So again, distal radius, we look at the thumb, this is the front, this is the back, And we see that as in relation to the proximal aspect, the distal radius is slightly in front. So it is volally displaced. So simple low energy extra-articular fracture, which is volally displaced, is called a Smith's fracture. So this is just a clever way of describing. So if you tell your consultant, just seen a 52-year-old male patient who's coming in after a history of a fall and they've got a Smith's fracture, and I think we should manage this, you look a bit much more clever, and they'll think highly of you as well. A Barton fracture now is a intra-articular fracture, and there's an element of dislocation at times of that. So this fracture, as you can see on this lateral X-ray, if you come all the way through the posterior cortex of the radius to the top, and you can see just about there, there's a step, and it just comes to the front there. So this is the fracture that has been fractured through the joint, and it's displaced volally as well. So I know most people, when they talk about a Barton fracture, we always think about the volar Barton fracture, but it can also be a dorsal Barton fracture as well. So again, the way you describe it, if you describe it that way, the Barton fracture, already in your mind, you're thinking about there is something that I need to do about this fracture in terms of fixing it, because you have to follow the principles of trying to fix these fractures. All articular fractures, you want an absolute reduction with complete with primary bone healing. So you want to fix this surgically. So once you say Barton fracture, you want to think about a surgical fixation. And once you say that to your consultant, they already know what you're thinking about next in terms of how to treat these fractures. So it's a good way of describing these fractures and then showing that you have a knowledge of how to address them going forward. What are the goals of treatment? So our main goals of treating these fractures, I think it goes without reason. We always want to restore the anatomy, but after you've done that, you want to make sure that this patient is a functional hand and wrist. So you also want to promote bone healing. You allow early wrist and elbow exercise. So whatever treatment you're giving, you want to allow them to start moving their wrist and elbow, and you want to avoid complications. I think when it comes to the hand and the wrist, they swell quite easily. And unfortunately, with the hand, swelling means stiffness means pain, and pain means loss of function. So the sooner you get them moving, the better, based on the treatment you would have given them from the start. So again, it's no use to have a good good anatomically reduced fracture if the hand isn't working, because ultimately, in the end, we want to restore these patients back to their baseline, to go back to their work, to go back to caring for themselves as well. Then I know we discussed the radial height initially, the inclination and the volar tilt. And there are some acceptable radiographic criteria that you can look at. So if the radial height, you want to at least try and fix it and make sure that there's less than 5 millimeters of shortening after you've sorted it out. And radial inclination, at least less than 5 degrees as well, when you've fixed it as well. Although you want it to be anatomical as possible. The volar tilt, you want it to be less than about 5 millimeters in dorsal angulation and within 20 degrees of contralateral of the other side of the hand, which is a part where you feel it might be important when you're operating in theatre to maybe screen the other hand. If the hand of the patient doesn't look completely normal, but you feel like you've completely reduced it, so that can always help to look at the other side as well. Remember, we want, whenever we're treating fractures, to allow for absolute complete reduction. So you should at least have, at the very most, have 2 millimeters of step off, but you want there to be no step off altogether. So you want the articular surface to be completely congruous. So treatment options. I think in orthopedics, it's pretty straightforward. Whenever you treat patients, there's always an option of not doing anything or doing minimal, so non-surgical or surgical. And by and large, conservative treatment is mainly closed reduction plus or minus casting, or just simple splinting as well, depending on the nature of the fracture. So if it's an undisplaced simple fracture, patients coming in, moving their hand, you can just give them a wrist splint and they can go home and they'll be fine. But if it's the displaced fracture and if it's the dorsally displaced fracture that you think can you fix conservatively, then you should consider trying to reduce it. So the main indications for treating patients conservatively. Usually these patients are patients who are elderly. These are patients with maybe multiple comorbidities, or the fracture itself is minimally displaced and you feel you've got a good chance of putting it back in place. Extra-articular fractures that are dorsally displaced can also be treated conservatively as well. I know there's no hard and fast rule, and with experience, you will find that there are some fractures with intra-articular extensions that might end up being treated conservatively based on the patient, based on expectation, and based on the fracture itself. If it comes back nicely after a reduction, then you might well and good try and run with it and see how far it goes. If you then consider to try and fix treat this patient conservatively with a closed reduction, you want to do it with the patient as comfortable as possible. And there are different options in terms of based on settings, based on experience, and based on different hospital trusts. I know some people just use simple analgesia for that, which can stretch all the way from just paracetamol, ibuprofen. Some people then use morphine IV to try and calm the patient and control their pain whilst they reduce. In some centers, they advocate use of a hematoma block. So basically what you're trying to do is usually you use lignocaine. Some use a combination of lignocaine and marcaine or bupivacaine, which is a bit longer acting. And you want to go where the fracture is, with about 10 mils usually. Go with just palpate. Obviously, you want to do it as an aseptic procedure. Clean the area, have a feel of where the fracture is and where the step is, and you just want to inject just about between the two fractures there, the local anesthetic, and that usually tends to try and helps with the pain. But I think in the UK, the both guidelines advocate for a regional block. And in our center, we use what we call a PS block. So basically, we put a cuff in the upper arm with two. So it's a double cuff in the upper arm, and then you put a cannula there, and we use prilocaine. When you put the cuff in, the cuff is to limit blood flow past the cuff, so that once you've put in your anesthetic, our prilocaine, it stays within the lower arm, so that it anesthetizes the arm altogether. And you can do it quite comfortably. The patient will not usually complain, and they'll be fine. They'll be awake, discussing with you, and you'll be taking them through the procedure as well, in terms of which helps them have a better understanding of what is happening and what they need to do as well afterwards. Then some centers advocate for sedation, and in some select patients, particularly pediatric patients, you might end up having to give them general anesthesia to try and keep them calm and pain-free. So I know people. I'm speaking from people from different countries and different trusts. So you probably will know what you guys do at your own trust. I don't think there's a right or wrong way, but of doing it, as long as it gives you the best results. But I know the British guidelines, the post guidelines, advocate for a regional block. So how do we reduce a fracture? So the main fractures we're trying to reduce are the dorsally displaced fractures. So in a patient who is adequately anesthetized, either simple anesthesia, hematoma block, BS block, which is number one for us, you want to apply longitudinal traction. So usually, at least you need 3 people. You need one pulling the hand, the other person pulling around the forearm to the elbow, and you need someone who is going to apply a cast or a back slap, whatever you trust do with acute fractures. So give it about 1 to 2 minutes. Usually I go for 2 minutes with sustained longitudinal traction. So you want to avoid any jerky movement. So you just apply simple traction for a bit of time to allow the muscles to relax. And once the muscles have relaxed, all you want to do is have a feel where the fracture is with your hand, over-exaggerate the deformity. If it's a dorsally angulated, dorsally displaced fracture, over-exaggerate, which is pulling the wrist out to the back, but mainly you're pulling the fracture side to the back. And with your thumb, just about where the fracture is, you want to apply pressure, 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 and then volarly angulate the fracture to try and hitch it back in place. Once you've done that, you can only deviate, hold it in position, and then a colleague of yours who's applying the plaster can then apply the plaster. And you want the plaster to be molded, as demonstrated in this diagram, volarly, just about where the fracture site is. You want 3-point molding. So at the fracture site there, above, and distally as well, which holds the fracture snugly in place. And once you've done that, you really want to watch this like a hawk to make sure that the fracture doesn't displace any further. So in our trust, the guidelines are you want to see it, you want to see the patient again in a week's time, repeat the radiograph, assess the fracture, assess the neurovascular status again to see if the patient's okay, and then see them again in 2 weeks' time, assess the fracture, assess the patient, and to see if the plaster is okay as well. If they're okay there, usually you can then see them again at 4 weeks' time, at which point you should be aiming to remove the plaster altogether and give them a lighter rest sprint for about 1 to 2 weeks. So that's how we would usually treat it, and it seems to work so far, touch wood. So there are some drawbacks with the plaster. I think the early ones that you might notice with most patients that there might be a tightness of the cast. It doesn't tend to get to the full extent of having a compartment syndrome, but it's just something to be aware of, that you can cause a compartment syndrome by applying a very, very tight cast. Also, there's what they call, if you overflex the wrist as well when you apply the plaster, you can cause a lot of pressure in the carpal tunnel, and that can result in acute carpal tunnel syndrome. And that could also be just as a result of the fracture and immediate swelling after the fracture. So it's things that you have to be aware of. We know that the fracture can malunite, hence why we want to see if the fracture is displacing in the early weeks. And non-union, which is less common in distal radius, thankfully, but you can tend to see them in elderly patients as well. I've placed the EPL rupture there as a complication. If you remember the Liston's tubercle that I mentioned there, so at times after the fracture has been treated conservatively, everything's fine, patient's gone home, they're back to work, no problems, everything else is going on, everything else is going well. They might all of a sudden wake up one day and feel, oh, I can't really lift my thumb up. And because when we treat fractures, they heal by secondary fracture healing, which means they start healing with colors first, and which then remodels and then smoothens with time. At times, even when these fractures heal, because if it's gone through the Liston's tubercle, just about where the EPL tendon winds around going to the thumb, the surface there is no longer smooth, so it becomes an attritionary injury. Over time, as you're moving your thumb, it's rubbing on that new colors or on that new uneven surface, and slowly the tendon is being torn until it eventually ruptures. So these are less common acutely, but more common. But then if they do present, they can present maybe after years, at times after months. I've seen one who presented, I think, after 2 years after having been treated conservatively. Surgical treatment. So I think there's a few options of treating these fractures surgically. I know in some centers people treat these fractures using percutaneous pinning with K wires. Some surgeons advocate for open reduction and internal fixation using volar locking plates. I know in the past people used to use dorsal locking plates, but those have slowly fallen out of favor because I think they were associated with a high risk of EP or ruptured or tendon injuries as well. Because if you have a look, I think the dorsal aspect of your wrist is more subcutaneous, and so the plates would rub off and cause more problems as compared to the volar plates that we use now. And in patients with open injuries or patients with quite, I would say in the simplest term, smashed wrist fractures, an external fixation would be important. It just gives you some bit. If it's in a smashed fracture, you want to give some ligamental taxes just to stretch up the ligaments and just to allow the fracture to heal in a reasonable position. It's one of those fractures that you think are very difficult to reconstruct, but also in open fractures. So indications for surgical treatment, open injuries, if in case maybe you've seen a patient, you've treated conservatively, but 1 to 2 weeks down the line, it's slipped back out of place and you feel like, okay, this is not going to do very well, then you can then rethink, discuss with the patient again, and then offer them surgical intervention. If there's any articular comminution, step, or gap, and you feel that this will lead to radiocarpal arthrosis and arthritis down the line, then it's something to consider for surgical intervention. And fractures that are significantly displaced, if they're extra-articular or even if they're comminuted as well, because unfortunately, it's difficult to hold and restore radial height in fractures that have significant comminution because there is no buttress mode, and that's usually been lost as well. If there's a loss of volar support, so those fractures that I've described, the Barton fractures and the Smith fractures that are volarly displaced, they tend to usually just require surgical intervention. Again, this is not an exhaustive list. It just gives you an idea of the ones that we tend to treat surgically. These will be different from hospital to hospital, from country to country, so based on, I think, availability of resources, surgical expertise, and just treatment protocols in different hospitals. So how do you do percutaneous pinning? Again, these patients would need general anesthetic usually, or a regional block. So if they've been adequately anesthetized, the aim really would be again to go through that whole process of reducing the fracture. Nicely, once you've reduced the fracture and you feel it's in a good place, you want to do this with fluoroscopy in theater in a very sterile environment, and then you put K wires. There's different techniques of doing it. So there's usually going to be a K wire coming from the radial styloid all the way, holding the distal fragment and trying to hold it to the proximal fragment as well. And there's usually also another wire that comes from the back, particularly in dorsally displaced fractures, which acts in two ways. Obviously, it's holding the fracture in place, but also you can use it as a wire to reduce the fracture in what is described as a Kappanji method. So you can either, it's basically providing you external or extension blocking of the fracture. How you perform the Kappanji method, So how you perform the Kappanji method of trying to reduce these fractures at times is you can go where the fracture is. So if the fracture is at the back, you just go where your initial KY can come through the back where the fracture is. You've reduced the fracture and you then hold it onto the other cortex. That will stop this fragment from pushing at the back because there's something supporting at the back. So that's one way of doing it. You can also use the Kappanji method if the distal fragment, which is this one, is radially translated. You can take a wire, put it through this the fracture fragment on the radial side, try and reduce and hold the outer side of the distal radius. Sorry, to try and hold it in place. But these techniques, I think, you will then learn as you go forward in your training and as you do more and more and see more and more of these fractures. After you've done pinning, the aim would be to then put these patients in a plaster, and they can usually stay in a plaster for up to 6 weeks. The aim is to remove these K wires at 4 to 6 weeks, and this depends on the surgeon as well, preference, treatment plan, and their protocols. But usually 4 to 6 weeks is a good ballpark number as to when you want to remove these wires. A bit earlier in younger patients, because they tend to heal quite quickly as well. And then again, you'd also want to see the patient in clinic again, maybe usually at 2 weeks, to have a look at the wounds, to do another x-ray to see if the fracture is displacing, and then at 6 weeks from the time of the operation. And then if you're going to do an open reduction and internal fixation, I know previously, excuse me, people have described the Henry's approach, but what we tend to do now is we do the FCR approach, which is the flexor carpi radialis tendon. So excuse me, you try and make an incision just above that. So I think, as you can see on this diagram of the patient making a fist, there's on the left side you can see the palmaris longus, but if you make another fist quite strong enough, you can see that the FCR is just slightly radial to the palmaris longus, and you want to make your incision just about there. Obviously, this is happening in theater. The patient is anesthetized and adequately, I think, relaxed as well. You want to do this with an upper tourniquet to avoid any blood flow. But again, that's different surgeons prefer different things. Some surgeons don't use a tourniquet, but I prefer using a tourniquet because it gives you good access and you can see the surgical field much clearly. Once you've made a longitudinal incision just about there, clearly dissect the soft tissues quite simply until you get to a point where you're seeing more of this fracture. You're seeing the brachioradialis, which and then you're seeing also the palmaris longus, and you're seeing the PQ is much more deeper as well. So you want to dissect all the soft tissue until you get to the PQ, and use retractors along the way. And the PQ is the last muscle that sits on the distal radius. So I think if we go back to the first diagram, our volar anatomy, just as a demonstration of where the PQ would be. So the PQ would be more or less sitting just about there, and quadratus, so more or less like a square. So it's just about sitting just about there, and you really want to peel it off the radius and then reflect it towards the ulnar side. And once you've done that, it allows you to see the distal radius, and that's when you get to see the fracture. And then, depending again on your skills, you then reduce the fracture. After you've reduced, you can either hold it first with a K wire, and then you want to fix it with a plate. And this is more or less how it's meant to look. So this side here, where my mouse is the hand, and this side here is towards the elbow. And this here is a volar locking plate, and the kind of plate and screws that we would use. And you can see this is where the fracture would be, and your plate is just basically sitting bang onto the radial bone. And ultimately, that's what you want to do. And this is how it would look on X-ray. This is probably a few weeks down the line, I think. All these images were taken from the internet, so I've got no claim to how nicely or badly they look. They look very nice, actually, to be honest. And then, again, what we were saying initially, you can see that volar angulation has been restored. You can almost see that radial height looks fine as well. and that radial inclination looks just about fine. And your screws are all inside in a very good position. You can see that DRUJ, the ulna, is sitting just about next to the radius there. And there's no obvious screws that are trying to penetrate into the joint. There's no obvious screws that you can see that are trying to penetrate into the joint. So that's holding the fracture nicely in place. And how you rehabilitate this patient depends again on your center. But the good thing about after you've done an ORIF and you put a plate and screws in there, you can try and mobilize the patient as soon as possible. So ideally, you'd aim to review them in 2 weeks. You want to see the wounds at 2 weeks to see how they're healing. And at that point, if you put a back slab or a volar slab, just for comfort usually, you can take it off and just give them a simple wrist splint. You can encourage them to start doing simple wrist movements and see them again at 6 weeks for a final review of an X-ray. You aim to avoid loading for the first 3 months because I think, as you're aware, the fracture is, the plate itself is not strong enough to take the load of the different things that people might live, particularly depending on the different occupations altogether. But by 6 weeks, you should be able to pick up a cup of tea or a glass of water. Again, it's surgery, so it does come with some drawbacks. There are risks, including regarding infection. There's some documented risks of EPO rupture, particularly with the dorsal plates, but you can still get it with the volar plates, but however, very, very rare. I've, I think, seen just one case where patients have had, I think, chronic FPO rupture, which again creates the debate of, after you've exposed the pronator quadratus, do you repair it or do you leave it as it is? There's varying, I think, schools of thought. Some people say you have to repair the PQ because then it avoids the plate rubbing on the tendons rubbing on the plate directly when the patient is now moving their thumb. But I think from experience, to be honest, it's not very easy to repair the PQ because it's usually quite torn. It's probably maybe at times even more retracted and smaller, and it's difficult to really put it back together in place. But most of us tend to agree that just covering the plate altogether after the operation is maybe not doing a full PQ repair, but just allowing some of the muscle to cover the plate might be very helpful going forward. We know there's a median and ulnar nerve in the vicinity and the radial artery as well. They all need to be protected using retractors. There is a small risk of malunion, and this goes down to principles of whether you've not fixed it, you've not reduced it very well from the start, or in patients with very osteoporotic and the screws are not just holding it very nicely. There is also a risk of screw penetration. So ideally, you want to be certain that your screws are in the right place. You want to do different views. So you want to do a complete lateral X-ray of your wrist. Then you also want to, what shows you the joint line better is about a 10-20 degree. If you lift the wrist by 10 to 20 degrees as you're doing your II image in theater, it gives you a better shot of the joint itself to see if the screws are penetrating the joint. Stiffness is something that we have to worry about, and some of the patients end up having to see the hand therapist who will help guide them with movement and massage and dealing with stiffness of their hands. The acidic side of complications are always there. So again, you want to avoid doing this operation in patients with multiple comorbidities who are elderly, frail, and with very low, I think, expectations in terms of what they're going to do with their risks. So it's again discussing with the patient, making sure that they're aware of the risks, and then making a decision thereafter. Thank you. Any questions?
Thanks, Stan. Welcome questions and clarifications. Please feel free to raise your hands and unmute and ask your questions. Or if you prefer, you can drop the message in the chat box and I'll ask the speaker. Thanks.
Yeah, I know. I think we've got, from what you told me, Shola, that we do have a different, I think, pool of, audience in terms of different levels of experience. So I encourage you to ask any question. I think we're all learning, and there is no right or wrong way. We can try and find and make an answer together and work together. So feel free to ask.
I think we'll just wait 1 or 2 minutes, see if any question comes up. Otherwise, we can conclude the session. Thanks, Stan.
Okay.
I think you must have done a thorough job of going through all the basic bits and pieces. I can't see any question in the chat box, and I don't think nobody has raised their hands or unmuted to ask any questions. So I think the absence of go on.
Yeah, I thought someone would ask me that. So, which fractures do you treat with the K-wire, and which fractures do you treat with ORIF? Because it's a big debate that's going on, and you will find that different centers treat these fractures differently. For those who have time, there's what's called a draft trial that was done in the UK, I think around 2015, which looked at treatment of displaced distal radius fractures with K-wires and with open reduction internal fixation with a volar locking plate. Interestingly, they found that there was no difference in outcome, and that patients did well either way. And we know that K-wires are way much more cheaper than getting a volar locking plate. But I think from experience, unfortunately, this doesn't completely tally as well, because we know that those fractures that are quite comminuted, extraarticular fractures, they then tend to reduce in height with time. Whether that then ultimately makes the outcome poorer, I don't know. And I think there's a draft 2 trial that is ongoing at the moment, which might address some of those questions. So it's something maybe to think about. Just going, if you can go through and just, I think it's DRAFT draft trial, something just to read about. Just if you have any interest in distal radius fractures, just to make you aware of why people make these decisions of treating these patients differently. Because I'm pretty sure there's some centers that treat these with just K-wires, and they seem to be happy with the way things are going.
Thanks, Mr. Masunda. There's a question in the chat box. So it says, based on practice in UK, how long after an acute fracture, where you have placed the back slab, will you ask the patient to come back for a full cast? I presume this is asking about a a fracture that you are managing conservatively. You've probably MUA'd, you've put them in a reasonable position in back slab. When do you want to get them back in to convert to full cast?
That's a very good question. I think that depends. So usually you want to do it within a week, so you can bring them back within a week and put them in a full cast. I think in our center we start all of them. We tend to see them. So the first time we see them, we don't reduce them. We see them after 48 hours to within a week, and we do the manipulation under BS block, and then we just put them into a cast altogether from the start. But I've worked in different centers where they put them in a back slab and they then complete it in a week's time. So I think that's a very good question, because people do things differently. You don't want to leave it up to 2 weeks, because the back slab also doesn't look very nice at 2 weeks, and is also very loose at 2 weeks as well.
Excellent. Thanks, Mr. Masunda. I think if there are no more questions, I think it's been a fantastic session. Thanks for coming again to educate us on this lovely, quite essential topic. There's a follow-up question for you, a quick one, Stan.
Yeah.
I think Dorcas is asking, in your trust, what do you do in the first 48 hours? I think it's a follow-up to
Oh yeah.
your answer.
So it's a simple back slab. So the first time they come in, and that's the advantage of working in a, I want to say, first world country, because they do have a lot of resources as compared to where I started working at home. People buy their own plasters. Here you can put them in a simple back slab. You can put them in you can put them in what are called finger traps, initially for about 30 minutes. So if you think about a drip stand, and then there's two finger tongs that hold the fingers up, and then you put two saline, maybe two liters of saline on the arm to try and just reduce the fracture for a bit, and then you just put them in a back slab for 2 days, and depending on availability of this. I think we call it a BS block service, where they are brought back again to have their fractures manipulated. So they usually come in after 2 days to about a week latest to have that reduced. So the first time, just either just put them in a simple back slab or put them in finger traps to try and reduce the fracture just a bit if it's overly displaced, and then put them in a back slab, and then they'll come back in 2 days.
Yeah, thanks, Stan. I think the other thing to add, just like you've quite rightly highlighted, that the practice differs across hospitals, across trust. And sometimes some of these fractures are not too terribly displaced, and A&E puts them in a back slab after manipulation under hematoma block. Some of them are not too swollen, and you find people actually put them in a full plaster and bivalve the plaster, with the hope that in case you get too swollen, you can comfortably take that off. So, it's just about doing what is safe, and adapting the management plan to the peculiarity of how the patient presents, the fracture pattern, level of displacement, etc.
Yeah, and particularly resources as well, because
true.
If you don't really have the resources to do a BS block, then maybe it's not the right thing to do. If you have anesthetists lying around everywhere and they are happy to anesthetize or sedate patients, then maybe that's the right thing to do as well. I think it's just tailoring however you treat these patients, working with them, giving them the choices, discussing the options that are there, and allowing them to make a decision.
All right, thanks a lot, Stan. Thank you, everyone, for attending. I think till the next time when we bring in another session. Thank you, everyone.
Thank you, guys.